by Dr. Rogelio De Jesus. So it's from the Philippine Heart Center and PGH. So next slide. So basically what we'll do here is discuss plain film anatomy of the heart on the chest radiograph, then some plain film interpretation, then maybe the valvular heart disease we'll discuss in the next lecture. So the objectives of the lecture is to review the cardiovascular anatomy in plain chest radiographs, discuss the basics of cardiovascular assessment in plain chest radiographs, and to show the radiographic signs of common valvular heart diseases. So why the chest radiograph? Because it is the most commonly requested diagnostic tool in radiology. It's least costly and frequently effective. It's actually an essential part of cardiac evaluation. So what do you get from the chest radiograph? You can evaluate the heart size and silhouette. You can also evaluate for enlargement of your cardiac chambers, and also you can also evaluate the pulmonary blood flow and markings and vascular markings. So the evaluation of the chest film with the cardiac patient involves sequential logical assessment and correlation of both anatomic and physiologic information available on the posterior, anterior, PA, and lateral chest radiographs. So we go first to the plain film anatomy. So discuss pa rin Dr. Anton Tabato yung mga borders. So we'll just review. So on the right upper right upper hemithorax, that is actually the area of the superior vena cava, and below that is the inferior vena cava. So next slide. So on the right side of the heart, the border there is the right atrium. That is what? Anong valve to? Anong valve yan?
Tricuspid.
That's the tricuspid valve. So next side. Your right ventricle is actually actually in the midline, but you do not see that on the frontal projection because it is anteriorly oriented or located. So it's the area of the right ventricle. So what valve is this?
Pulmonary.
Tricuspid.
Pulmonary.
Bagsak ang balikan na. Pulmonary. That's the pulmonic valve. So that's the pulmonic valve. So, balik mo muna. So on the PA projection, your right ventricle does not form any border of the heart. So on the PA projection or frontal projection of the chest. So next slide. So this is what, after the pulmonic valve, that's your main pulmonary artery. So it branches into your right main pulmonary artery. It's actually mediastinal in location. You don't see that in the frontal projection of the chest. What you see are already branches. So this one is actually the main branch you see in the area of the hilum is actually the right descending pulmonary artery. So you don't see the right main pulmonary artery on the frontal projection because it is mediastinal in location. So this is the main pulmonary artery segment, and this is your left main pulmonary artery has a shorter course compared to your right. So the main branch here is actually the left main pulmonary artery. So next slide. So just above the base of the heart, that's your area of the left atrium. So you don't really see that also in the frontal projection because it is located posteriorly. So all your pulmonary veins drain into your left atrium. So anong valve to? Anong valve yun?
Tricuspid.
So that's your
Ay, mitral.
Ah?
Mitral.
That's your mitral valve. So that's the mitral valve. So next slide. So from the mitral valve, that is your left ventricle. It forms a border on the left side of the heart. So that's your left ventricle. So next slide. So after the left ventricle, that's your ascending aorta. So normally your ascending aorta does not form also a border in young patients in the frontal projection of the heart. So ayun yung branches of the aortic arch. So this one is your main pulmonary artery, right main pulmonary artery, left main pulmonary artery, then the branches. So next slide. So ayun yung mga location of your valves. So remember the location of your valves. That's important actually when you're already doctors. Knowledge of the location of the valves will be important. So always remember where the valves are located. So typically they will replace what? The mitral valve. Especially in patients with valvular disease, the mitral valve is the most common valve that is replaced in patients with valvular disease. So you must know the locations of your tricuspid. This is your mitral. That's your pulmonic valve. This is your aortic valve. So next slide. So again, remember on the right border, that's your superior vena cava. The right side of the heart is formed by the border of the right atrium, and inferiorly, sometimes you see a density there, that's your inferior vena cava. So next slide. On the left side, that's your, on the upper portion, the superior portion, that's the border, the area of the aortic valve. Then that's your main pulmonary trunk, then your left ventricle. So these are the bulges that you will see on the frontal projection of the chest. So next slide. So these are your right pulmonary arteries. That's actually already the right descending pulmonary artery. So next slide. So that's your left main, you can still call this your left main pulmonary artery because your left main pulmonary artery is a shorter course compared to your right main pulmonary artery. And your left atrium is posteriorly located, so you cannot assess the left atrium on a frontal projection of the chest. So next slide. So on a lateral view, that's the location of your superior vena cava, inferior vena cava. That's the right atrium. That's your tricuspid valve. So next slide. So your right ventricle is anteriorly located in the chest radiograph. So you can evaluate the right ventricle in the lateral view. So normally, if you divide the retrosternal space into 3 parts, the right ventricle occupies only the lower third of your retrosternal space. So if it occupies more than a third of your retrosternal space, that's a sign of enlargement of your right ventricle. So that's your tricuspid valve. That is your right ventricular output tract. So this is your pulmonic valve. So next slide. So again, that's your main pulmonary artery. So it actually hooks over your left main bronchus. So the more superior and posterior vessel is actually your left main pulmonary artery, while the more anterior and inferior vessel is actually the area of your right main pulmonary artery. So this one is located in the mediastinum. So that's how we locate the right and left main pulmonary arteries. So on the next slide. So your left atrium is posteriorly located. So actually anatomically contiguous with the bifurcation of the right and left main bronchus. So So that's your left atrium where your pulmonary veins drain, and this is your mitral valve. So in the lateral view, your left ventricle, aside from forming the left side, the left border of the heart, it also forms part of the the posterior half, the lower half of the posterior and lower half of the cardiac silhouette in the lateral projection, and superior to it, that is your left atrium. So next slide. So that's your left ventricular outflow tract, your aortic valve, ascending aorta, aortic arch, then descending aorta. Okay. So that's the appearance of your right ventricular and left ventricular outflow tracts on a lateral view of the chest. Diba? Nilecture ba ni Dr. Cabato to? Pareho lang yata kami ng slides di ba? Pareho kami pinagnakawan. Ng slides. Pareho kami ng pinagnakawan ng slides. Sige, next. Diba? So yung naman, the slide is, yung slide ni Dr. Jesus is for general distribution naman. So remember that left atrium more superior. So notice ito yung bite. This one the air-filled bronchi. So it's very near to your right and left main bronchus. So and lower that, and the lower border is formed by the left ventricle. So anteriorly, that's the area occupied by the right ventricle. So normally your right ventricle occupies only the lower third of the retrosternal area. So it does not occupy the more than 2/3, or does not occupy more than 2/3 of the retrosternal space. So and remember the outflow tracts, your aorta, main pulmonary artery, and inferior vena cava. So this located on the lateral view, that's actually the location of that one is your left main pulmonary artery. It's the area of your right main pulmonary artery. So this is what we call the pulmonary vein confluence. We see the crowding of vessels there. That's actually pulmonary veins that drain into the area of your left atrium. Okay. So we go to ito wala. So actually one of when we read chest X-rays, you must follow yung mga these guidelines. You must have a systemic approach in studying the chest radiograph. So you have an overview or overall glance of the field. So you must check the cardiac position and situs. Check the cardiac size, check for any chamber enlargement, check the great vessels, and also the lungs, and you look for any ancillary findings or incidental findings on the chest radiograph. So one of the questions we ask is the chest X-ray adequate or optimal for cardiac evaluation? So next slide. So these are the things as a radiologist considers: the position, inspiration, and exposure. Okay, next slide. So position, slight degrees of rotation or obliquity will substantially affect the cardiac contour and may alter the apparent size as well. So next slide. So inspiration. So normally the patient should be in full inspiration. That means that the level of the diaphragm is at the level of the 6 to 7 anterior ribs, and posteriorly it should be at the level of the 9 to 10 posterior ribs. So we count where the level of the total diaphragm is located. So in suboptimal inspiration or supine chest radiographs, the lower lobe markings are crowded and may obscure the possibility of early pulmonary edema. So another thing to consider is exposure of the the film, whether it's dark or very white. So other exposure, that means that the X-ray is white. Other exposure may simulate the appearance of pulmonary congestion, while overexposure or when the film is too dark may simulate diminished pulmonary blood flow. Ito, diniscard pa rin ito para makabalot. Hindi na yun, sa kanya. So cardiac position, so this you should know these things also. So when we say levocardia, the heart is predominantly in the left chest, and the cardiac apex points leftwards. That's the normal levocardia. Dextrocardia, the heart is predominantly in the right chest, and the cardiac apex points rightward. While mesocardia, the heart is positioned in the midline, and the cardiac apex points directly inferiorly. So there's also such a thing as dextroposition or dextroversion, where the cardiac apex points leftward, but the heart is located predominantly in the right chest, typically due to extrinsic causes. So we also assess for situs or visceroatrial situs. Situs refers to the pattern of anatomic arrangement. So your atrial situs is usually concordant with visceral situs, hence these are described together. So when we say situs solidus, the morphologic right atrium is to the right of the morphologic left atrium. The gastric air bubble is on the left side and the liver is on the right. So when we say situs inversus, the morphologic right atrium is to the left of the morphologic left atrium, and the gastric air bubble is on the right side, and the liver is on the left side. So that's right. So when we say situs ambiguous, this term is used when identification of visceroatrial situs is not possible due to paucity of anatomic markers. So this one is what? So dextrocardia, situs solidus. So notice that the heart is mainly on the right side, diba? And the cardiac apex points towards the right side. So that's their dextrocardia, but this one is still normal situs solidus because the liver is on the right side and the gastric air bubble is on the left side. So that's how we describe chest radiographs. So next slide. So this one is dextrocardia again. You have the heart is mainly on the right side. The cardiac apex points towards the right side. So notice your gastric air bubble is at the left, the right upper abdomen, right side, and the liver shadow is on the left side. So that's your dextrocardia with situs inversus. So this one is situs ambiguous because you don't know where the liver and stomach are because of a lot of gas is interfering in the upper abdomen. So that's your situs ambiguous. So we go to the ABCs of heart disease. Alam niyo ito, nilagay ko rin Dr. Cabato.
No, question about the third.
Ay, third to,
Previous pa.
Yan.
Since the heart will be at the right, will it make the right lungs smaller compared
Hindi, pareho lang. The same lang yun. The same lang yun. Same volume lang yun. Sige. Okay. So we go to the ABCs of heart disease. So what is it? What it is? It's actually an approach. It's actually for congenital or acquired heart disease in adults. So actually you can diagnose heart disease in plain chest radiographs. So you're asking a systematic set of questions. Answers are based on certain fundamental observations and visible on frontal chest X-ray. So you can actually diagnose heart diseases with just a plain chest radiograph. Diba? So yung cardiothoracic ratio, sinabi ni Dr. Cabano, lecture ba? Ha?
Hindi yata.
Hindi niya sinabi kung ano yung cardiothoracic ratio? Sino yung mga tulog agising noon? Diba? So one of the important things we measure is what we call yung cardiothoracic ratio. So the cardiothoracic ratio is the widest diameter of the heart. So that points as compared to the widest internal diameter of the ribs. So we measure from the inner aspect of the rib. So normally the cardiothoracic ratio is less than 50%. That's the normal cardiothoracic ratio. In adults, that's the normal cardiothoracic ratio. In children, the ratio would range from 60 to 70%. Okay. So next slide. So how do you do this? You divide the how do you do the cardiothoracic ratio? So you divide the widest transverse diameter of the heart by the widest transverse diameter of the thorax taken at the inner side of the rib cage. So don't get the outer rib cage. It should be the inner side of the rib cage. So normally we measure at the level of the dome of the diaphragms. That's how we measure the cardiothoracic ratio. So next slide. So sometimes the CTR or the cardiothoracic ratio is more than 50%, but the heart is normal. So these are the extra cardiac causes of your cardiac enlargement. This one is portable AP film. So because the patient is in a supine position, because your heart contains fluid, so it will expand within the supine position because of the fluid. So it will enlarge the heart. Also obesity, when you're fat, also the heart gets fat, it gets wider. If you're pregnant, because it's a compensatory physiology of the heart, because you're supplying to the mother and the baby. So that's a compensatory hypertrophy of the heart. If you have also ascites, because ascites pushes the diaphragm upward, so it will make the heart bigger. And also your straight back syndrome. The straight back syndrome causes narrowing of your AP diameter of the chest. So it also compresses the heart. And also pectus excavatum, alam niyo yung pectus excavatum? Yung, diba? So it also narrows the AP diameter of the heart, so it compresses the heart. So it will make it a lot bigger than normal. So these are the extra cardiac causes of cardiac enlargement. So this one is the heart size is larger than 50% of the cardiothoracic ratio, but it is still a normal heart. Why? Because there's an extra cardiac cause for the apparent cardiomegaly. So they took a lateral view, so they found out there's an inward displacement of the lower sternum due to pectus excavatum deformity. So that pushes the heart more posteriorly. So that actually increases the heart size, therefore increasing the cardiothoracic ratio. So sometimes the CTR is less than 50%, but the heart is abnormal. So what are the one of the causes is obstruction to outflow of the ventricles. If you have ventricular hypertrophy, that can also produce a normal heart size, but actually there's already a pathology in the heart. So you must examine always the cardiac contours. So next slide. So here is an example of a cardiothoracic ratio less than 50% of the, but the heart is still abnormal. So there's recognizable, this is recognizable because there's an abnormal contour to the heart. So there's, ito diba? That's a prominent ascending aorta. So these are the cardiac contours that you must the 7 cardiac contours that you must know. Silhouette of the ascending aorta, then the double density of the left atrial enlargement, that's your right atrium, the aortic valve, the main pulmonary artery segment. So this is the indentation for your left atrium. that should be normally concave, and the left ventricle. So these are the contours we check out on the chest radiograph. So next slide. So only for this lecturer, the important contours are the top 5 only: your ascending aorta, aortic knob, the double density of the left atrium enlargement, the main pulmonary artery. So this is the area of the main pulmonary artery. So this one is the left main pulmonary artery. This one is the density for the main pulmonary artery. And this one, inferior to that, is the concavity of the, or indentation of the left atrium. So normally, sabi niya, we'll look at each of the cardiac contours. So ascending aorta, so that's it's always low density, almost straight edge. It should be straight. That represents the size of the ascending aorta. So next slide. So normally it should be small, like this one, diba? That should be small. So, and if that's prominent like this one, it could be, there should be a convexity. That's actually a prominent ascending aorta. So the ascending aorta can be small, as in the example on the left side, or prominent as example on the right. So as stated, the ascending aorta should not project further to the right than the right heart border. So it should be, yung right cardiac border mo, it should not exceed that right cardiac border on your chest frontal PA radiographs. So the border of this should not exceed the border of your right cardiac border. So that's the normal appearance on your chest radiogram. So how about the double density of the heart? So normally your left atrium does not form a border on the right side of the heart, but when it enlarges, it forms another border. It produces another border here and produces another density here. That's what we call your double density of the left atrial enlargement. And it also produces what we call the so-called double density bump of your left atrium. So, but this one is the right atrium. So if the left atrium gets bigger than normal, it may also form, aside from the double density, it will form another border here or bump. So that's what we call the double wall sign for left atrial enlargement. Okay. So even though we are on the right side of the heart, we can see left atrial enlargement. So normally the left atrium sits right in the middle of the heart posteriorly and does not form a normal border on the frontal projection. So this is actually the area of your left atrium. So this on CT scan, diba? Anterior, posterior, right side of the patient, left side of the patient. So that's your right ventricle, left atrium. So normally your left atrium does not form a border. So it will form a border when it exceeds the border of your right atrium. So that's the typical orientation of the heart on your chest, diba? Right atrium, left ventricle, posteriorly that's your left atrium. Okay. So when the left atrium enlarges, it will do something on the left side of the heart. So we'll talk about that in a minute. So it may produce a double density. So normally you have a uniform density. Because of the enlargement of the left atrium, becomes hypertrophied, it receives more X-rays, absorbs more X-rays, it produces this density at the upper portion of the heart. So that's what we call the double density of left atrial enlargement. So here, the There are two shadows, the yellow arrow pointing to the left atrium and the red arrow pointing to the right atrium. So there's a what we call a double wall side. So they overlap each other where the indentation between the ascending aorta and the right heart border meet. So this is what we call the double density side of the left atrial enlargement, or what we call also the double wall side of left atrial enlargement. So this is the border of the right atrium. This is the border of the left atrium, double density side or the double wall side of left atrial enlargement. So next slide. So the last bump on the right side is the right atrium. Since there is no disease in an adult that causes isolated enlargement of the right atrium, we'll consider the right atrium together with the right ventricle later. So normally, there's not much pathology with tricuspid valvular disease. So in adults, the right atrium is not really important in assessing for cardiac enlargement. So next slide. So on the left side, we go to the left side. The first bump on the left side is what we call the aortic arch. So we can measure the knob from the lateral border of the air in the trachea to the edge of the aortic knob. So normally, that should be less than 35 millimeters. What I do is measure from the midline of the spinous process of the thoracic spine. I measure from the spinous process of the thoracic spine to the edge of the aortic knob. That's 4 millimeters. That's what I use. You can use either from the trachea, lateral border of the trachea. That's 35 millimeters, or from the spinous process of the thoracic spine. That's 40 millimeters. That's the upper limit. Okay, so you can assess. So that's the way to assess the aortic knob, it's dilated or not. So next slide. So the aortic knob can be enlarged or greater than 35 millimeters or 40 millimeters with. So these are the causes of an enlarged aortic knob. You have increased pressure in the aorta, you have increased flow, and also changes in the aortic wall can increase the size of the aortic knob. So next slide. So we go to the main pulmonary artery segment. This is one of the more important vascular structures we assess on the chest radiograph. That's the next bump after your aortic knob, and is the keystone of this system. So that's important also. They put red on it. So how do you find the main pulmonary artery? So from the aortic knob, you go down. So this is the slight bulge here. That's the left main pulmonary artery. So adjacent to that, more medial, that's your main pulmonary artery segment. So you have to be able to find the main pulmonary artery. There are two ways. It is, first you locate the first bump below the aortic knob. That's one way. So next. The other is you look for the left main pulmonary artery. So immediately medial to it is the main pulmonary artery segment. So that's how you locate the main pulmonary artery segment in two ways. So next slide. So we actually can measure also the main pulmonary artery. So if we draw a tangent line from the apex, cardiac apex of the left ventricle to the aortic knob, so that's the one line, and measure along a perpendicular, along a perpendicular to that tangent line. So that's the yellow line. So that's actually the measurement we get. So the distance between the tangent and the main pulmonary artery, between the two small arrows, green arrows, falls in the range between 0 touching the tangent line to as much as 15 millimeters away from the tangent line. So you can measure the distance also. So this is the border of the main pulmonary artery, that's your tangent line. So you draw a perpendicular line, so the distance should be from 0 to 15 millimeters. So next slide. So the range of normal for the main pulmonary artery segment is from 0 to 15 millimeters. So you actually can do that, diba? From the cardiac apex to the aortic arch. So there are two major classifications. So the main pulmonary artery segment projects beyond the tangent line. So the main pulmonary artery is more than 15 millimeters away from the tangent line. So that means that because the MPA is small or absent, or because the tangent line is being pushed away from the MPA. So this one is the projects beyond the lines. So when it projects beyond the lines, so that means that the measurement is more than 15 millimeters. So that means there's convexity of your main pulmonary artery. So that indicates that could be due to two causes. There's increased pressure or increased flow in your right ventricular outflow tract. So the second possibility is if the main pulmonary artery is more than 15 millimeters from tangent, so it could occur if the main pulmonary artery is small, as in what? So this one is the very concave view. The main pulmonary artery segment is concave. That could be due to truncus arteriosus or tetralogy of Fallot. So if it's more than 15 millimeters from the tangent, so this more commonly occurs because the left ventricle is enlarged or the aortic knob push the tangent away because your aortic knob is also more than 35 millimeters or 40 millimeters from the midline. So these are common. So you must consider this. It's a common finding. So to review, the distance between the tangent line and the main pulmonary artery should be between 0 to 15 millimeters. So again, with left atrial enlargement, concavity where left atrium will appear on left side when enlarged. So this is when the LA enlarged, also the left atrial appendage or left atrial concavity is also affected. The next contour is a slight concavity where the left atrium will appear when it enlarges on the left side. So this actually, main pulmonary artery, this is the concavity for the left atrium. So we also call this the left atrial appendage. So next slide. So the more when we look for signs of left atrial enlargement, one of the more common signs is what we call straightening of the left heart border. So we check this if there's straightening. Normally there's a slight concavity. When we see straightening of that border of the left heart border where your left main pulmonary left atrial appendage is located. So that's one sign of left atrial enlargements. Also, aside from the double density and double wall sign. So as stated there, normally your left atrium does not form a border of the heart in the frontal projection. So this one is an example. So in the example on the right side, not only is the left atrium enlarged, but the left atrial appendage is also enlarged. So there's already convexity of the left atrial appendage. Outwards, there's a slight bulge. So this one is actually the normal. It's the mild concavity of your left atrium. So that's the abnormal, that's the normal. Very slightly back. If you're not an astute radiologist, you will miss these things. So you're straightening notice the straightening. Normally there's a mild concavity. So that's what we look for when we look at chest radiograph. So even though it's a chest radiograph, we must study it very well. So next slide. So I'm lucky I had a very good consultants where I studied. Diba? When I was a resident, so they pushed this ano,